Good afternoon, everyone. Thank you for joining us today for the Clinical Trials Methodology course webinar series. Today's webinar is on data management. But before I introduce our presenter, I want to mention that you can use the chat box if you have a question or comment, and you can unmute yourself by clicking on the audio icon to the right of your screen. Also, please remember to evaluate the webinar at the end of today's session, and I will post that link in the chat box at the end of the session. Also, our next webinar is on August 6th. It's an office hours one regarding the review of safety and adverse event reporting with the course directors. So you will be getting a reminder on that. So our presenter today is Catherine Dillon. She is the Associate Director of Trial Operations at the Data Coordination Unit with over 15 years of experience in clinical trial management. She has provided oversight for a broad range of trial operations activities for over 75 clinical trials, including phase 1 through 3, multi-site, international, industry, and federally funded, network, emergency, and exception from informed consent trials. So her responsibilities have included leading the project management, data management, on-site monitoring, and regulatory activities for the clinical trials conducted within the unit. So thank you, Catherine, for presenting today.
And thank you, Joy, and thank you, everyone, for joining us. I'm sorry, did I interrupt you, Joy?
No. I see that you brought your slides up, so that's perfect, and I can see them perfectly, so thank you.
Okay, great. Well, thank you, Joy, for that nice introduction. So my name is Catherine Dillon, and basically I'm a data nerd. I love data, especially clinical trial data. And I'm going to be talking a little bit about quality data management, specifically in clinical trials today. And I work at the Data Coordination Unit, which is an academic clinical research organization housed within the Medical University of South Carolina. We're located in Charleston, South Carolina, so if you ever come this way, come visit us. And we provide a variety of support for many clinical trials. We do project management, data management, statistical support, ISIT support, monitoring, regulatory, so a full range of support for clinical trial operations and management. But today we're going to focus specifically on the data portion, which is near and dear to my heart. So we're going to talk a little bit about what are the risk factors that pertain to clinical trial data quality, and how we can prevent such problems, and how we can detect such problems if we can't prevent them entirely. So that's going to be that's a quick and dirty overview of what we're going to be discussing for the next hour or so. Joy, just to confirm, it's an hour, right?
Correct, yeah.
Perfect. I don't want to start talking and have that all wrong. So, okay, great, thank you. Okay, so first, clinical trial data quality risk factors. Okay, so there's lots of things we need to do. So good clinical practice, or GCP, tells us what needs to be done, right, in order to build quality into our clinical trials. And then the statistician and usually the physician or the scientist work together to develop the study design, and that's where we plan what we're going to do in our clinical trial. And then the physician or the investigator and the study coordinator work together to operationalize the trial at their site, and they do what is planned. And then the data manager and the study coordinator work together to do all the data management and actually record what is done. Okay? And when all of that is done correctly and exactly, we should have a successful trial. Okay, and remember, a successful trial is not a positive trial. A successful trial is one where we answer our scientific questions. It could be positive, negative, or neutral, but it reflects the truth of what's happening in our world. Okay, and so if we do all of these things exactly as we should end up with a successful trial. But likewise, if we have any sort of problem along the way, we can result in a failed trial. So there's lots of different steps along the way, and we need to make sure that we're managing everything correctly across all of those steps. Okay, so what are the causes of failed trials? So if a treatment effect does exist, you should have a positive trial. And if a treatment effect does not exist, you should have a neutral or a negative trial. And again, both of those are successful trials because it's telling you the truth. But we have situations where that's not always the case. So you can have a scenario where the treatment effect does exist, but you have so much signal dilution going on that you end up with a neutral or a negative trial. Or you can have a situation where a treatment effect does not exist, but you end up with a positive trial, and that could be a result of bias or fraud. Okay, so those are the things we really need to prevent against, right? And again, our goal is to find out the truth, positive, negative, or neutral. Okay, so what are the problems with a failed trial? They're numerous. So it can be a situation where you can't recruit enough patients, and this can be because maybe your eligibility criteria are too tight, or the procedures to operationalize the trial are just so complex that the sites really don't want to do it. The science is not there. Okay, you could have too many research aims with excessive clinical assessments and data collection demands on limited resources. You could have an unstable study design where you have a messy, sloppy protocol and frequent protocol amendments. And you could have potential bias or fraud, where situations such as maybe your randomization method is vulnerable to selection bias, or your assessment is vulnerable to assessment bias. So, and we're going to talk about all of those a little bit more. So excessive trial operations, we only have so much time and energy and money on our hands, right? With limited resources, the more you have to do, it suggests that you're going to have a lower quality of your product. So really focusing in on what's important and not the, well, I'd like to look at it, I might want this, I might need that. And here are just some examples. So Rampart was a clinical trial that we did through the NET network. And it was a large, simple trial. And you can see we had a total of 8 case report forms, unique case report forms, and a total of 178 unique data items, 2 study visits, and so a total of 9 CRFs are posted for a subject. It was a great trial. It won Trial of the Year award at the Society for Clinical Trials meeting in 2013, and it's changing the way that people with status epilepticus are being treated in the ambulance before they make it to the hospital. So it was a great success. Okay, here's an example of a complex trial. This is our PROTECT trial, which was also done through the NET network. And you can't even see the data collection schedule, I'm quite sure, because it's incredibly long and incredibly cumbersome. There were 44 unique case report forms, almost 1,300 unique data items, to 40 study visits per subject. So you could end up with a total of 353 case report forms per subject posted. It was a very, very, very labor-intensive study. After 882 subjects were enrolled from 38 sites, after 4 years, the study was terminated in 2014 due to futility. Now, do we say because it's a large, complex trial, that's why it was shut down? Not necessarily, but the point here is that you don't have less. More is not always more. Sometimes less is more. And you can have really good, positive, successful trials that are very lean. So, okay. Talked a little bit about, too much. Too much is too much. And we're going to go on and talk a little bit about investigator assessment bias. Okay. So in this case, this is the Hamilton Rating Scale for depression. This is the assessment done at baseline, and this is the assessment that was done after treatment. This is the site rating, the clinical assessor, and on the bottom is the independent blinded assessor, who is blinded to both time point and subject and treatment. Okay. And you can see here, so a HAM-D score, the lower the HAM-D score, the better you are. So the less depressed you are, higher, the lower your score is. So you can see at baseline here, on average, the clinical assessor rated the HAM-D higher at baseline than compared to the blinded assessor. After treatment, they came in lower. So on average, at baseline, the clinical assessor rated the assessment 2 points higher than the blinded assessor. And after treatment, the clinical assessor was rating the HAM-D 2 points lower than the blinded assessor. Okay, and this difference is really close to the treatment effect that we were trying to collect or trying to detect in the first place. So really, it speaks to the need for using a blinded assessor. You know, bias isn't something we do intentionally; it's just there. So we need to do all we can to prevent against it. We can also talk a little bit about suspicious, or in this case, selection bias. In the TPA study, I'm not saying that there was selection bias there. I'm saying it just looks a little weird when you start looking at things. In the NINDS TPA stroke study, there were 31 subjects who had randomization glitches. 26 of those were in the TPA arm, and 5 of them, only 5 were in the placebo arm. So that seems a little weird. You would expect randomization glitches to be sort of equally distributed across the 2 different arms. And then even stranger, in the randomization glitches, out of the placebo arm, 1 ended up in the TPA arm, whereas 21 in the TPA arm ended up in the placebo arm. You can see the p-value there. Okay, what else can kill our trial? Well, we could be missing our primary outcome. So when we're missing our primary outcome, we usually do something statisticians call imputation, which is fancy statistical speak for making up data. Okay, so you don't want to make up data. We might be enrolling patients that are all too healthy, in which case they're all going to be a success. Right? In both arms, everybody's going to do great because they're all healthy. Okay? Or we might be enrolling patients who are too sick. So no matter what, they're just too darn sick. Doesn't matter which arm they're in, they're all going to fail. Okay? So when you have these cases here, whether they're all too healthy or all too sick, they all look the same, right? You don't have any difference between the 2 groups. You can also end up with treatment crossovers, and this is especially horrible for an intent-to-treat protocol. So in an intent-to-treat protocol, subject is analyzed in the arm to which they were randomized, regardless of what treatment they were actually administered. Okay? So if you were randomized to TPA but you received placebo, you are being analyzed in the TPA arm, but you're diluting that treatment effect because you didn't get any treatment. So having a subject with these kind of errors is worse than not enrolling a subject at all. And in fact, in the case of the treatment crossover, ITT analysis, to recover the power loss for 1 such error, you need 2 more subjects. So it's better not to enroll a subject at all if you're going to have one of these errors. Okay. So, and why is this? So let's just have sort of a visual here. We've got our treatment that looks very different from our placebo, right? But we start introducing trial operation errors. And this is in real life. The 2 arms are different. There is a treatment effect. It exists. They're different. But we introduce our trial operation errors, and we enroll ineligible patients. Then we have some treatment crossovers, and then we have some non-adherence to the treatment. So everybody's looking like placebo because nobody's taking anything. Then we have assessment errors where we're just making errors in our primary outcome, and then we've got missing primary outcomes, so we're making up data, and all of a sudden our treatment arm and our placebo arm look exactly the same. So that's what we're talking about here with our dilution of the treatment effect, the dangers it can cause to our trial. So the quality of a clinical trial starts from the design. Operation errors dilute the treatment effect. We just saw how that happened. And data managers can't fix these problems, right? Once the problems have already happened, there's nothing a data manager can do to fix your data. But we can help to prevent it. We can prevent trial design mistakes and operation errors, and with a focus on risk, preventing these problems that can really sabotage